economists generally think about value in terms of what consumers of a good are willing to pay for it. So the value of an iPhone is what people who use the iPhones are willing to pay for it. So in the case of healthcare, the question is, what are patients willing to pay, or even people who buy health insurance, what premiums are they willing to pay? That in itself is a relatively uncontroversial proposition. The difficulty is figuring out how to determine what patients will pay for drugs or other kinds of health technologies, and that tends to be a more controversial issue. The US has a bit of an exceptional system for drug pricing, although in fairness, just about every country has its own form of exceptionalism in drug pricing. But in the US, it's typically been a market-based process where the government has relatively little input into pricing other than indirect levers. I shouldn't say little input, they're just indirect levers for input into drug pricing. So we have not really gone about the process of trying to quantify value and ensuring prices are aligned with value under the belief that markets, when they work well, will naturally align prices with value, just like they do for iPhones. We don't worry about value-based pricing for smartphones because we know that consumers will only pay the value that the phone brings to them. The problem in the market for drugs in the US is there's so much intermediation and such a disconnect between the consumer on the one hand and the manufacturer on the other, and the presence of intermediation by an employer that is providing insurance, an insurer that is providing the insurance to the employer, and then a pharmacy benefit manager that is helping to negotiate the drug prices. All of those layers involve different incentives that cause the price to depart from what consumers really feel or perceive as the value of the drug. And on top of that, quite frankly, patients don't always know what the value of a drug is. It's very difficult to make an inference about the value of a drug. So even if we aligned those incentives, it would be a difficult problem to solve. I think here's where it becomes a real problem for society, and really everybody on planet Earth is impacted by these kinds of problems, because the prices that accrue to innovators for new drugs determine, A, the amount of effort they put into innovation, which is important, but perhaps even more important, it affects the kinds of innovation they want to bring to market. So if we're not consistently providing the richest rewards to the best drugs and the poorest rewards to the worst drugs, if we're not doing that, we can no longer ensure that the pharmaceutical industry will consistently respond to that signal and bring the best drugs to market. And that's where we're doing patients a disservice by not encouraging the right kinds of innovation. And that's what the stakes are really for getting value right in pricing. Well, it is also relevant to note that the vast majority of drug candidates fail in testing. In the US, even if you focus on the set of drugs that make it to human trials, which itself is a tiny fraction, 88% of drugs fail before they get launched. So that cost has to be recouped by the monopoly profits that you refer to, and that's correct. But then once the successful drugs are launched, there is a period of time in which a manufacturer has to recoup those investments. They're not literally figuring out what were my costs and I'm going to charge cost plus markups or something like that. But effectively, the value that they bring to the market and are able to harvest in the form of revenues is the remuneration for all of the innovative investments that they've undertaken. And then theoretically, at some point, the drug goes generic and becomes cheap and widely available. One of the challenges has been that patents have been extended through various kinds of mechanisms. That companies have gotten quite adept at exploiting rules around extended market exclusivity. And in some cases, drugs end up being protected and having some degree of market exclusivity for 20 years or more. And in that sense, there's not that period for society to kind of gain really the lion's share of the reward for consumers, which comes after these drugs go generic. And I think that's part of the problem. It's not the only problem, but it's part of the problem. So we need value-based pricing while drugs are on patent. We need that period of time when drugs are off patent. And we need insurance to protect consumers against that monopoly pricing while the drugs are on patent too. I think it's a hard problem that it's going to be a long road, but I think that there are some steps that we should be taking now to begin on that path. One of them is we need more and better information about value. And it's fair that in the US we have not involved the government in price setting, and we don't have to necessarily. But one of the consequences of that is that we've also deprived the market of resources, government resources, for the production of information about value. And without that kind of information, we just get decisions that are worse, that are not as well informed, prices that are not as well informed. So I think funding value assessment is part of the issue. I think another step that could be taken is there are regions of the pharmaceutical market where insurance is really an impediment to the well-being of consumers. For generics in the United States, the generic pricing process actually works pretty well, and it only gets gunked up by insurers who step in and see it as a mechanism to harvest profits and rent from the system. And you can see that this is true because oftentimes insured consumers are paying more for generic drugs than uninsured consumers, which makes no sense. In fact, insurance, if anything, should be lowering prices for insured consumers, and it's just prima facie evidence that the system is broken. And I think creating a cash market for low-cost generics would be a nice first step towards rolling back some of the distortions of intermediation in the market for drugs. You know, it's interesting that I don't think as a profession, meaning health economists, I don't think we know what the right price level is. So I think it's not fair to say that the UK is paying inefficiently low prices any more than it is to say that the United States is paying inefficiently high prices. But what we can say, we can just take sort of a positive view of this, meaning just how do we think about the behavior? And there it is true that the United States generates profits that are out of proportion to not just its population size, but even its income. You know, the U.S. is roughly 40 or less than 50% of global GDP, but it generates probably close to 3/4 of global pharmaceutical profits. That's a fact, and whether it's too high or too low can be debated. In some sense, it's not so surprising because if I were running a small country, necessarily I would understand that the effects of my pricing policy on global innovation are trivial. So if you're running a small country, the right thing to do for your country is, in fact, to go for low prices because you're not going to have an impact on global innovation. And I think in some sense it's unrealistic to believe that smaller countries will, in fact, do their best for the rest of the world without an incentive. Now, Britain is not necessarily a small country, and in some ways Britain has disproportionate importance because many others look to the UK for guidance on how to value drugs, how to pay for drugs. I think that's where the UK has played a leadership role, and I think it can actually take that and move it in even more constructive directions to improve the way that we assess value, which I think has been broken for a number of years. And I think we need to align the science of value assessment with the preferences of real-world patients. And I think that now we know how to do that, and the UK is in a position to really move that debate forward, maybe even more so than the United States is.